you go.
There you go. Frank, you with us now?
Up for the day.
We lost you there.
They can't hear me.
No, I can hear you now, but right from when you said hello until right now, we'd heard nothing that you said. Our screen went blank.
Oh, your screen went blank?
Yep.
Oh, okay. Well, so basically I said that we're on the short rows and we're fixing to finish up for today. So we chose a case. We've got two cases actually. They wanted to see the end of my last case that I did. Was unable to see it. We're going to put that on the screen. Can you see that on the screen right now?
Yes, we can.
Frank, we got some people from up north. You might not be able to use terms like short rows.
I can barely hear him, y'all. We did a silver hawk and ballooned it, and then we delivered drug to it, and we still had a dissection. And what bothered me was the antegrade dissection that you have right there. So we decided that we would go ahead and treat that. Next one, please. And we just put a short self-expanding stent in there, and got excellent results. Go to the next one. And our runoff was actually much better than what it was beforehand. So that's the final of the last case that we just did.
Right.
Before this one. Getting back to this one, this is a 76-year-old gentleman. Unfortunately, he suffers from the ravages of tobacco use over the years. And so, unfortunately, he has developed Rutherford 3 symptom-limited claudication, mostly in his right lower extremity. And I'm going to run through some of his pictures. We've actually, you can go ahead and bring that down. Had a balloon up for just 2 or 3 minutes here. I know y'all don't believe that. But this is his initial angiogram. You'll see he's got multi-level disease. He has iliac disease. Actually has a 45 millimeter gradient across that. His ultrasound suggested common femoral, and that's why I chose him, because I thought that would be a good case, but unfortunately the ultrasound was not correct. It did not have common femoral, but he has diffuse SFA disease, which actually is something we see on a very regular basis, and it's clearly our nemesis. We know that these long diffuse lesions are difficult to treat, and also they have a tendency to come back. Running on down his leg, you see his popliteal looks pretty good, but he does have some small vessel disease at his trifurcation, and he's lost his posterior tibial, obviously, and his tibial perineal trunk is diseased. But today we're working on improving his inflow. We've treated his SFA, and on the way out we'll treat his iliac disease. Are there any questions at this point?
No, I think you say you've already treated the SFA, or that's what you're going to do for us now?
Could you push that in my ear? You're pushing it out of my ear. All right, we've already treated it. What we did is we took we just checked in its common femoral, and this is our setup angiogram. And we took a 2-3 laser, even though he did have quite a bit of calcification in there, and we lased both the proximal and distal segment. And if you'll see, we took our time lasing too. We went very slow and did several passes at high energy levels, and we got pretty good results.
Hey, Frank, this is Ray Datillo. Just one comment, if I might.
This is post-laser right here.
Frank?
Yes.
One comment with regard to the iliac disease.
Yes.
It's just, just for the audience, important to recognize that you need to make sure that there's enough space around that sheath so there's no decrease in flow down the leg. Sometimes a balloon dilatation and an iliac lesion can help prevent that kind of complication.
Well, I appreciate your comment, and unfortunately you can't see my hemodynamics. He still has a pressure of approximately 100 millimeters of mercury in his sheath at this point in time, which is past the iliac lesion. So I feel pretty comfortable with that. Otherwise, you would have to balloon it or treat it early on before you proceeded with the more distal vessels.
Okay.
May not want to stent it. Don't like to stent and put a sheath across it. Have done it, but don't like to. Sometimes I'll balloon them just to give me enough room.
Right. So go on to, for interest of time, treating the SFA. You've now lased it and you kind of optimized your lumen there. Are you now looking at some type of drug-coated balloon versus drug-coated stent versus
What I did is
POBA?
we POBA'd it right now. And basically, I did this as a pre-dilatation because I have every intention of using a drug balloon here because the length and diffuseness of the disease, we know we're going to see it back. I mean, it's just going to come back, and you should do everything you can. You can either just do basic POBA or that looks pretty good. Or you can go in and treat it with, and wait for spot stenosis come in, but you also have to make sure that your patient is going to follow up on a regular basis.
And that was just a plain balloon. It wasn't a focal point balloon?
No, that's a plain balloon because I planned on doing a drug balloon, and I still plan on it. The balloon was up for 10 minutes up.
Okay. At what pressure?
And nominal 6.
Okay.
And then after it was up for about 5 minutes, we brought it back down to 4 and let it sit there.
Okay. And I think that's a great technique to try and minimize your dissection. It just has to be patient enough to be able to do it.
Well, you don't have to be waiting on y'all to finish in Detroit for it was.
Well, Tom was getting his orientation straightened out, so we had some problems there. So now, what is your algorithm?
We're straightening Tom out.
Yeah.
I did notice, and I'm going to say, I don't know if you heard me earlier, but I heard you say, unfortunately, we got to go to Mobile, and I don't know what to think about that.
Well, I just hate to leave Tom hanging there, but we're glad to see what's going on here. So what is your algorithm for when you use DCB and when you do not?
Well, to be honest with you, DCB is fairly new, and of course, anything fairly new, we get real excited about using it. And so I tend to use it a little bit more probably now, but you know, if it wasn't that I know this fella and he's not going to be that compliant, he's not going to put smoke in, I might just accept what I got right there and wait to come back later down the road. But right now, I think that knowing him fairly well, I probably won't see him for another year and a half until this thing would be occluded, and then you show back up. I think we need to treat him the best we can right now.
Yeah.
Hopefully get good long-term results, and might beg him some more to quit smoking.
Yeah.
This is a DCB, and this is the Medtronic DCB. It's treated a little bit different than the Bard, and it actually, as you well know, has a little bit more drug on it. But the data, we're still waiting on data to come out between the two as far as long term. We kind of got an idea, but as you well know, it's fairly new with our studies that are out there. You ready? You got that?
Right.
Got that water? Come on.
Yeah, I think we're all trying to figure out which one to use it, and quite candidly, if cost wasn't an issue, I would use it on everybody.
I agree. Okay, go up right there. This particular balloon, as you well know, the agent's a urea type agent. You don't have to worry quite as much. Well, let me check it for you. Okay, go up right there. You don't have to worry quite as much with the particular agent as you do about getting the balloon up faster, because it's not a glucose or sugar type agent, if you may. But you do need to, I think you need to get in and try to keep it just normal. Well, keep it from being washed out. It is delivering more drug, as you say. I tend to leave them up a little longer probably than most people. I think you ought to leave them up at least for 1 to 2 minutes. They do say 30 seconds, 60% comes off, but I think that a little bit longer is better, in this
Yeah.
case anyway.
Well, I think the recommendation is actually for 3 minutes, so you're still into that limit. But I think the drug is actually transferred within the first minute.
It's falling out. There you go, thank you. We're having all kind of technical difficulties in my ear today.
Okay. No, what I was saying is I think the IFUs, you should have it up for about 3 minutes, but the drug transfer, I think, has been shown to occur in the first 1 minute.
Go ahead and drop that other block.
Pat, what's your indication? When do you use?
I agree with that.
Just want to get Pat Muck in here to give us his thoughts.
Yeah, so we're still trying to figure out our indications as well, but typically we use it for shorter lesions with DCB, and as you mentioned, cost is quite a concern, I think.
Okay, so Pat was saying he's tending to use.
How does he? I did hear his response. How's he treating his long diffuse lesions such as this?
Currently, what we'll do is a long 4x200, just like you did. And then oftentimes I still use what still has the best 5-year prospective randomized data, which is Zilver PTX. So I won't line the whole thing with that, but I'll spot stent with Zilver PTX still.
Okay.
Frank, I have a question. Venki here.
Yes.
Does that
Venki, how you doing?
gob protect you more than your skull cap?
Oh, this?
Yeah. Is that better than your skull
This is,
cap?
zero gravity. Yes, this is better than a skull cap. It truly is. It's the very first case that we did today, I went through the zero gravity, and what this is I had some orthopedic problems, obviously, and was told I couldn't wear lead anymore, and so we ended up. This is the next best thing to keep me in the lab. This is a very heavy lead, and we actually put a high sensitive meter right inside the shield here. And I worked all day, and at the end of the day, it had zero radiation.
That's pretty good.
And I will say, I do feel a lot better at the end of the day than I did wearing lead all day. Go ahead and take it out.
So you need to balloon the distal SFA again with another drug-eluting balloon, because that's where your dissection is.
That's exactly what we're going to do.
So once you've gone in, you've done your balloon angioplasty, you get ready to do POBA or do the drug-coated balloon. If you have a residual stenosis, how much do you accept, and how much you then come in and say, okay, I need to stent this one?
I will accept a fairly reasonable residual stenosis because we do know there is some remodeling that does occur afterwards. If you've seen some of the other angiograms that were done post delivery of the drug, as well as if there is a stable dissection. You know, I can remember back before we had stents and all we had was POBA for SFAs when we did. We accepted some pretty nasty looking stuff at the end of a procedure, and we said, well, we can always come back.
Right.
And I do think the one thing you need to do, especially with a lesion such as this, is you have got to follow these people closely with ultrasounds at least at 3 and 6 months and 12 months, if not at 1, 3, 6, and 12. Just depends. Now, unfortunately, this young gentleman right here, I just don't think that's going to happen.
Mm-hmm. And you're more likely to intervene at a peak cell velocity ratio greater than 2.4, or when do you say it's time to go back and treat this, even if they're asymptomatic?
Well, I mean, or you could just follow them a little bit more. I need to take a picture of that, didn't I? Okay. We're going to go down. Go up right there.
And so now
Nice and slow. Nice and slow.
so you're making sure you have some overlap. What's your overlap generally between DCBs?
I typically overlap about 10 millimeters.
Okay.
Or thereabouts.
Yeah. I tend to be a little bit more, I go about a centimeter overlap. I think it's important that we make sure that you don't have that geographic miss where you think you've treated not. So that's where it's important saving your fluoro images and making sure that you step by step go through and treat all the exposed area.
Yeah, I agree.
And does the extent of the calcification that you saw in that more proximal segment, does that bias you one way or another to use DCB?
I'm sorry, would you repeat that?
Yeah.
You broke up.
I'm sorry. The extent, you see fairly extensive calcification in that proximal SFA above your DCB. What impact does that have on your decision-making process when you look, should I use DCB or do something else, like stenting or by the base of calcification, extent of calcification?
Well, I think, you know, the amount of calcification, I agree if they're, you know, depending on what you look like after you debulked, and also what you look like after you balloon. As you can see in the distal segment here, there is a dissection. Now that may or may not be a fairly stable dissection as you're running. It doesn't look as stable as I would like, and we may end up having to stent that segment right there. But as you can see, it moves a little bit. Careful there, buddy. And so as far as the decision making, I think it's what your outcomes are as you progress on in your procedure.
Okay.
You can take another view of that.
Yeah, I can.
And as I recall, he had pretty good runoff below that.
He did. He had some disease below it, though, unfortunately.
So he had that area. The AT looked very good, and you had the tibial perineal trunk disease. Would you not treat that now, or would you come back at a later date if he needs it?
I don't think we ought to go poking a skunk with a stick right now. I really don't. What I think we ought to do is just treat his inflow, see how he does. If we can cure his symptoms, doing it, come down to half, okay? You know, at least alleviate his claudication, get him to walking, maybe get him to quit smoking. If we can do all those things, we'll see how he does. Like I said, you can always come back and treat below the knee if we need to, if he continues to have trouble. Now, if he develops a wound, that's a different story.
Right, but since he's just claudicant, you're going to be happy with what you got, and maybe put a balloon up there a little bit longer, but overall, I think you got a great result.
Okay.
Right. Well, unfortunately, Frank, we have to leave you now, too, and come back to some more presentations here. But thanks for a great case, and we look forward to seeing you later in the meeting.
All right. Thank you very much.
Thank you.
Frank.
Bye-bye.
Okay. Now we get to move on with the didactics with interventional therapy of the popliteal artery aneurysm. When is it appropriate to consider? Dr. Rosing?